I'm very pleased to share this presentation with all of you. I am very good friend in the University of Calgary, and I'm very proud to present you some of my work according to the invitation by Hoda. So, yeah. So for start this presentation, I would like to share with you a quote by Blaise Pascal, a mathematician and philosopher French, that he said the total of a system cannot be to understand without to clearly understand the small part of this system, and we cannot understand the small part of this system if we don't know the total part of the system. So if we choose to talk about a hospital system, an hospital system, it is a three level in the sample form of the system, a three level system. The first level is the patient state as the statistical unit, the primary statistical unit. The second unit, it is the level 1 or 2, 1 and 1, the level 2. It is the ward of the hospital, and the level 3 is the hospital, the totality of the hospital, the whole hospital. And in this context, we can show that data need at the three level of the system, at the hospital length of stay, at the hospital ward, and at the wall of hospital. And we have also two levels of complexity. The most of the situation of healthcare and health are complex in terms of dynamic and stochastic nature of the system. And because there are many interaction and interconnection between individual, patient, and professional, but inside of the system, between ward, between 2 hospitals, 3 hospitals, etc. And because all the system is very complicated, very complex, not complicated, data are, of course, complex to assess this system. And the mix of the complexity of the health or healthcare system and the complexity of the data give a very important complexity of health system in the totality of the system. And I am working currently with Philippe Michel from University of Lyon and Jackie Stocklin from UC Davis in California to set a framework about the complexity of healthcare. And we assume that clinical expertise could represent the individual level with a complicated vision of health system and healthcare. And health and healthcare system organization could provide the complex vision of the system across three topics: the effectiveness of health and healthcare, the risk in terms of adverse events related to health and healthcare, and the cost and extra cost regarding to health and healthcare providing. And we have many factors or determinants according to the complexity and complicated of this healthcare. This is the topic of the predictable situation. versus the unpredictable situation, the interconnection and interaction between parts in the system, the time and the space of the system going on, the crazy toad innovating. It is a modality for change to adapt behavior according to unpredictable situation mainly. And the data structure, structured data and unstructured data. And potentially one key point is the interoperability between data, but also between different culture according the professional as nurse, physician, and many others. So this is imply one potential great challenge. The first is understanding the complexity of health system require understanding and mastering the complexity of the data and health information system more widely. In terms of the valid information provided by data, the ability to interpret the reality of the true life using this data, as an example for unbiased information, and to make possible a relevant decision making in terms of clinical strategy and policy, and how next generation of data system could improve the manner to better understand how health and healthcare are potentially complex. Okay, just okay. And accordingly, data and health information system are potentially the main support to better understand health and healthcare system, because data and health information system are potentially associated research topic to health and healthcare system. But one issue is also because data and health information system is also an independent research topic. And probably one challenge could be to develop in the same time both independent and associated research topic for data and health system, health information system. In the case of my talk, I would like to give you three main topics. The first is the use of electronic medical record in assessing the validity of PSI. PSI are patient safety indicator using ICD algorithm. Which type of data in supporting interpretation of PSI in order to improve the quality of healthcare? And the last question I will talk to you this night. This night for me and today for you. It is the expectation and prospect regarding ICD-11. So first, how we can use electronic medical record in assessing validity of PSI in terms of calculate the positive predictive value using chart review, paper version of chart review medical record, and electronic medical record, and how potential bias could be provided by different sources of data, and does one type of data may be able to be the perfect benchmark, the perfect reference in assessing and in evaluating the validity of PSI. So in our study material, we use three different PSI, the PSI 7 for bloodstream catheter infection, the PSI 12 for postoperative deep vein thrombosis and pulmonary embolism, and the PSI 13 about postoperative sepsis. We use the data from the University Hospital of Lyon in 2008, and we compare PSI, positive PSI, against a medical chart review manually, more or less electronic record data as a reference. And we then calculated PPV using the confirmed case, using the reference, divided by the addition of true and false positive case. So an important content previously is to clearly define the definition, the clinical definition of the PSI, to look for the appropriate information from medical record, paper or electronic medical record. In terms of the PSI 12, we categorize the two sub PSI 12 about the pulmonary embolism and the deep vein thrombosis, with different criteria to define the adverse event. And after that, we report the characteristic of this PSI using the national DRG system in France. Then we recalculate using only the database from the University Hospital of Lyon, and then we select only a selection of the positive case of the PSI. And we are significant difference mainly between the national database and the hospital database in Lyon. And when we calculate the PPV of this PSI, about 154 case of the PSI 12, positive PSI 12, we have different factors that discriminate different level of this PPV, and mainly for total hypertroplasty and knee troplasty, we have a very interesting high level of the PPV. And the second interesting point of this table is about the use of only the paper medical chart review with a PPV just over 70%. But when we use both in the same time, electronic medical record and paper medical chart review, we increase the PPV up to the maximum as 100%. It is very interesting about the role or the ability of the different source of data to improve the value of the true positive case of PSI. The second PSI we studied was the PSI 7 for bloodstream catheter infection. Exactly, we process exactly same using clearly define the criteria we need to search in the medical record for the validation of the PSI. We present the characteristic from the national database, and then from the University Hospital of Lyon, and then only the positive case of the PSI we selected for the analysis. And in the same way, we have different level of the PPV when we use only the paper medical chart review, 22% of the PPV. When we use only the electronic medical record, we have quietly 30% of the PPV. But when we use both together, the paper medical chart review and the electronic medical review, we increase up to 60% of the PPV. So for the last PSI we studied, we process exactly the same. We've defined the clinical criteria. We distribute and report the characteristics of the national database, local database from the University Hospital of Rio, and we selected the sample for PPV analysis. And in this result, we have two important information. When we use paper medical chart review only, we have a higher score, higher level of the PPV than when we use both in together a paper medical record and electronic medical record. But we have not the explanation of that, and we didn't find how we have a lower PPV when we use both paper medical chart review and in the same time electronic medical record. And potentially we suggest that this patient was a specific patient from one unit because in 2008 it is just the early start of the development of the electronic medical record at the University Hospital of Rio. And a second point could be very interesting in terms of the validity regarding which data use and which code use. It is the use of the code R578 because in France, this code is not for septic shock. It is clearly used for hemorrhage shock. And so we have a very high rate of false positive case due to this code. And we change this code, move to R572, and we increase then the PPV of this PSI. So this study I performed for my PhD thesis carry out the question of which data source we need to use to validate some outcome indicator derived from ICD data. And if you look for some different design about the collection of the data, prospectively, retrospectively, or in a cross-sectional study, we have very strong difference about what is measured by the free method, and this carry out the question about the validity of the data source in terms of what is the best data source to evaluate the validity of this indicator. And when we compare the data collected by two different professionals, healthcare professionals, registered nurse in a side and in another side by medical degree professional, we have a significant difference between both. So this suggests that we have two levels of interoperability from data. One is the type of the data source and the design of the manner of how we collect the data. And the second is the interoperability regarding the culture of the professional. And if we add medical data using DRG or PDRG system and nursing classification, it is a work from Welton in early 2005. This mix of the data could improve the ability to report the reality of the true life about outcome. What keeping in mind about this first question, probably data sources are essential in establishing a reliable and validate measurements. However, these data are very complex systems. For example, because they provide from different professionals with different culture of healthcare, by different support, by different manner, like the design of the collection of the data, prospectively, retrospectively, using cross-sectional method, and provide different measurement of the true life. And accordingly, no data source is perfect, and potentially the combining of multiple data sources can improve the quality of the measurement, as the PSI, for example. So the second question we need to carry out, it is which type of data in supporting interpretation of the PSI in order to improve the quality of healthcare. So for the first question, we have a position before the indicator are implemented on the reality, and now we are in the reality for the use of this indicator. Which data we can use as a benchmark, for example, for assessing the quality of a healthcare provider, for example, and which is the best, the HAEs benchmark, and how the PSI model may be used in assessing the highest quality of healthcare, and it serves as outcome for improving healthcare system. So for this question, I would like to present you an international comparison of a refined PSI, the PSI 12, only for hip and knee arthroplasty. As you can see previously, for these two specific patients, we have a high level of the PPV, so it's more easy to compare between countries, for example. So the first step of this project was to establish a reference standard for this comparison, to estimate the refined PSI using data from 5 countries, Canada, US, but only California, France, New Zealand, and Switzerland, and to perform comparison according to several determinants. So which reference to establish a reference for postoperative deep vein thrombosis and pulmonary embolism? In our sense, we discuss about the statistical mean using funnel plot as an example. But in this context, if whole hospitals are not very good in terms of patient safety, we are not the real benchmark according to the expected improvement in terms of ability for hospital. So we prefer to choose a clinical benchmark. But is the zero risk potentially good for us? Probably not. Using a baseline risk regarding to the best practices, using RCT meta-analysis, for example, probably yes, but in this case, we exclude some interesting patients with high risk of adverse event related to healthcare. And by assessing a baseline risk regarding the best practice in the true life, using rigorous observational study, could be a very interesting way to define the more relevant benchmark. So we perform a systematic review, including both RCT and observational study according strong criteria of quality for study. Included some colleagues from Switzerland like Bernard Bernan, from Lyon like Cyril Collin, and many Canadians, including Hoda and Bill at the UofC at Calgary. So then, after this assessment, calculating of the benchmark, ideal benchmark, we hope, we selected some hip arthroplasty and knee arthroplasty, patients undergoing appropriate prophylaxis to include study in this systematic review, include RCT and observational study, and we calculate the pool proportion of PE and DVT. And for hip arthroplasty, we found 0.5% of risk as a clinical baseline. And for knee arthroplasty, we find 1%. So for the international comparison, we selected only hip arthroplasty population. And we have a slightly difference between a low molecular weight heparin when we use observational study or RCT. And in our study, we choose as the ideal benchmark, ideal clinical benchmark, the mix between observational study and RCT for low molecular weight heparin. And then we perform an international comparison. We published that in 2018 in Medical Care. By first, we categorize the length of stay because our clinical benchmark from the systematic review of the literature concern patients from 7 to 17 days for length of stay. So we categorize the population between 3 lengths of stay category. The first is the very short length of stay. And it is very interesting to see that because for English language country, the most of patients have a very short stay. And for European country like Switzerland and France, we have not many people in this category. For extra length of stay, very long stay, it is very anecdotic. So we throw very fast on that. And for the same length of stay than the meta-analysis from the systematic review, between from 8 to 17 days. We have most of the population in the European country for this case, and some some people in this category from English country, mainly for the California. It is not these people in this category of length of stay is potentially not the length of stay that the source of the complication, but it is potentially the complication that is the reason of length of stay. And one point is very important for us. It is the very high, the very high level of the risk of the French population in this category. And when we compare French people and Switzerland people, we have a similarly exactly same population, the same sex ratio, the same mean age, the same length of stay, and we don't understand why we have a very a ratio between 4 and 5 for the risk of the VT. So we try to explain, look for solution why we have this difference. And we start by the number of secondary diagnoses for the PSI. We have some difference, but it is there are a correlation more the number of secondary diagnoses are, and more high is the risk of the complication. But if we choose the median of the number of secondary diagnoses, we saw that for 4 countries, we have the same median number of secondary diagnoses. And for the California, US, we have a very higher number of secondary diagnoses, but this is not correlated with the rate of the VT. So specifically for France, we have discriminate hospital according the rate of the ultrasound, the systematic ultrasound performed before patient discharge. And we saw that in the 4th quartile, we have a higher rate of VT, but this higher rate of VT is only concerned the DVT. So if we want to go ahead, we categorize, we give characteristic for each quartile of this hospital, and we saw that it is the type of hospital that provide the higher risk of ultrasound, is the private for-profit hospital that provide the higher rate of DVT, sorry. But for the median of length of stay, it is equal for all quartile. The average of the number of secondary diagnoses is quite equal, and it is the use of the systematic ultrasound, the first line of the table, provide the significant risk to detect potentially false positive case of DVT according to the literature. And when we have made this study, because in the OECD meeting for provide health at a glance, the French results are very bad every year, and it is due mainly to the rate of DVT, but not to PE. And we explain this difference because we use in France for 20% of the patient, systematic ultrasound provide a higher rate, a false positive rate of symptomatic DVT. This result changed clearly the strategy in France according to the quality assessment of healthcare, because this PSI refined for hip and knee arthroplasty became the first mandatory outcome indicator for patient safety, developed by the High Authority of Health in France, is the agency for the French Agency for Healthcare. Based on our result, this outcome indicator named now HAEs, and they use since 2016 with public disclosure since 2019. What keeping in mind about that, the choice of the benchmark is fundamental in order to interpret the quality and safety measure with relevance. And in addition, the relevant interpretation of this indicator, the PSI 12 with refinement to focus on hip arthroplasty and knee arthroplasty, should the basement of the decision-making for change habit, behavior, and organization in health and healthcare, and indirectly in terms of cost of healthcare. Because in France, we have decreased the rate of systematic ultrasound and decreased naturally the cost of healthcare. And in the last, what we can expect from the ICD-11 to improve the understanding of the complexity of health system using complex healthcare data, and how the ICD-11 may be able to support better healthcare complexity assessment regarding the patient safety in our talk, and which prospects for coding process. Two key features are from the next revision of the ICD, focuses on health services research, health evaluation, quality of healthcare and patient safety assessment, performance assessment, in addition to the volumetric evaluation. And the volumetric evaluation to provide the DRG and the rate of the reimbursement move in a second position according to the ICD-11 potentially. And how? Because the development of new coding convention based on the capturing healthcare complexity, for example, the causal relation and causal inference. So I just saw some few examples because the paper is under submission. Just I take just two examples. The example of a woman with contract a vaginal infection after a vaginal hysterectomy because the surgeon left a gauze in the vagina during the procedure. And if we need to code this situation, using ICD-10, we use only the code T81.4 for infection following a procedure, not elsewhere classified. It is not so detailed, not so precise in terms to understand how is complex this situation. But when we will move to ICD-11, sorry, I left in French the term, I'm so sorry for that. We cut the complexity. What is a harm? The harm is a surgical site infection. For that, we use the STEM code 1, NE81.2. What is the cause? The cause is a gynecological or breast procedure associated with injury or harm use. And we use a second STEM code. And how is a mode in terms of the mechanism to move from cause to harm? It is another STEM code, and the final code, it is not only one code, it is an algorithm of code from ICD-11 to code the complexity of this situation. Another situation now, a patient we have who has a central venous catheter, and this central venous catheter is infected with a Staphylococcus aureus, and this complication is due because a nurse make an error at individual level in terms of failure of sterile precaution in managing this catheter. But this error occurs because potentially in the unit there are an excessive workload in terms of it is a factor related to the organization level. If we use the ICD-10, we use only one code, one superficial code, like T85.7 for infection and inflammation reaction due to other internal prosthetic device, implant and graft. But when we will move to ICD-11, we code the harm by one stem code, the infectious agent by an extension code to characterize the microorganism responsible for the infection, and the different modality of the infection of the central venous catheter occur, like failure of sterile precaution as mode of injury and harm, operator error as mode of injury and harm, but we have not specific code to code the excessive workload of the organization. And finally, we have a cluster, an algorithm of the code with many code, both a stem code and extension code, to precise how this infection occurring. So the great challenge of give by the ICD-11 is to make the difference and to assess, to carry out potential relation, causal relation and inference causal relation to describe a complex situation. The key point is to determine the level of certainty of this causal relation and potential inference causal relation, and we can use all these terms in the table for implying a clear relation, but not to assess clearly the relation, and some term not implying causal relation. I have a bug. I need to restart Zoom. Sorry. Do you understand me?
Yes. Yeah. Are you having trouble with the presentation?
Yeah. I just one slide more, and after I finish, I just need to share my screen. Do you so? Okay.
There we go. Yeah.
Okay. I just do one more. So the new challenge regarding coding using ICD-11 need for a lot of detail about the clinical situation and their environment, how factors could be interact between them, and numerous data source, combination of several data sources will be needed. The need for strong intelligence in searching information from many databases, analyzing whole potential combination of data, using Bayesian network as well, using artificial intelligence, including deep learning and machine learning as well, and individual and collective human intelligence from practitioners mainly. And the last, in terms of conclusion, because the health system is a very highly complex, strongly complex, we need to develop a very strong focus about the complexity of the data to assess how the system of health is complex. And potentially, we need for developing integrated vision of health and healthcare system, including real and truly pluri and interdisciplinary approach maybe by developing a multi-core competency profile like a physician and engineer, nurse and engineer, a specialist of artificial intelligence with core competency of a medical degree or nurse degree as well. So I would like to tell you thank you for helping me, and I hope I so clearly for you, and my English is not so bad. So thank you.
For more information on who we are and what we offer, visit our website at coming.ucalgary.ca/CHI. If you are interested in our services, collaborating with our team, or have any other inquiries, contact us via email at chi@ucalgary.ca.